Perfect. Okay, I'm Katie, and I'm going to go over NG tube insertion today. So you want to make sure you gather all your supplies. Obviously, you need to have an order in the chart. We have different sizes of NG tubes. 14 French obviously is going to be the smallest, and we go up to 18. That's going to be a bigger bore. If obviously you want to go with the smallest size to make your patient comfortable, but also look at the size of their nair. And if you're solely going to be taking contents out of the stomach, I would maybe opt for a slightly bigger tube just to help with the suctioning, because a 14 French is the smallest that we, or probably not the smallest we have, but the smaller that we have on the floor. And they will tend to clog up and require a little bit more maintenance versus the bigger 18 is going to flow and take contents out of the stomach a little bit better. So you're going to have your suction tubing, you're going to have your NG tube, you're going to have your Lopez valve over here, which is just going to let you turn it on and off. Your anti-reflux valve, that's going to keep air in the tube, and then your syringe here. The connector is just to connect your suction tube to your NG tube. As far as your patient goes, you want to make sure you tell them what you're doing and let them know that it is probably going to be uncomfortable, might make them feel like they're going to throw up or gag. If they are able to swallow, we want to have them just practice taking a few sips of water with their chin kind of tucked down towards their chest. Tucking that chin down towards their chest helps kind of close the trachea a bit, and you're less likely to get it into the lung. Although if they're not able to do that, you can still pass an NG just fine. It's not something that they have to do. So as far as measuring goes, where you're going to be measuring from, and I'll grab the tube here. But if you're going through the nair, so an NG, you're going to measure from the nair to the corner of the ear, then there down to the xiphoid process, and then you're going to go about halfway down between the belly button and the xiphoid process, so about right here. That's going to be your measurement. If you're doing an OG, you're going to go from the corner of the mouth to the ear, down to the xiphoid process, and then halfway down. Obviously, when you're looking at what side you want to go in, you can take your pen light and you can look up into their nose. Notice if their septum deviates one way or the other. Obviously, if it's deviating over to the left, you want to probably go into the right side and vice versa. So be aware of what their nose looks like and how big their nair is. I always like to, once I measure, we'll lube up the tube really well. And I just very gently will go in one side. If I meet any resistance, then I automatically will go to the other side and try on that other side. Obviously, you're going to have a little resistance as you get to the back of the oropharynx, but you shouldn't have a ton. I'm going to grab some gloves. Probably don't need to video me grabbing gloves, but so I like to do my setup stuff with my patient just in a comfortable position. And then once I'm getting ready to actually insert the tube on my patient that is awake, I like to sit them up a bit. It just makes them more comfortable. And then if they do throw up for some reason, they're in an upright position and not aspirating. The other thing you always want to have set up when you're doing this is your suction, which I don't have here, but if I did, I would have it right here just to help out in case they throw up or get super gaggy. So here's your tube. You can get a Chucks, put it out over their chest too, just to help with any extra drainage or the extra lube that you'll have on the tube. Of note too, you can get an order for the lidocaine, like our Urojets. And the lidocaine can kind of help to numb up the nair when you're putting an NG tube in. Just make sure you get an order from the doctor first, and then to use that, you put a little bit of lidocaine up into the nair, and then you can put a little bit of lidocaine on the actual tube, you want to use some lubricant as well, but it does make them a little bit more comfortable to go in. Grab a little lubricant out of here. Okay, so what I'm going to do is pretend that this is kind of like my area with my chucks. I'm going to take my tube out, and then we're going to pretend that I'm going in through the nair because that's what we're going to be doing most of on the floor. So I'm going to take my tip here. I'm going to measure down, edge of the nair down to the earlobe, and then I usually just grab here. You can go the other way too. It doesn't really matter. Down to the xiphoid process, and then I kind of curl it, and then here I go about halfway down, so 55-ish is about where I'm going to go. So once I have that measurement, that's about where I'm going to want to go to. That's my goal to get to. Once I have my measurement, I'm going to set my stuff up here. I'm going to go ahead and open up my lubricating jelly, and I will tell you, the more of this you use, the easier it's going to go down. I usually use at least 2 packets typically, and I go down. I use 1 packet and I go down one side here, and then I take my second packet here, and I come down and do this part of the tube as well. Okay, so lots of lubricant on the tube will have to help that tube pass. At this point, I usually take my syringe and I'm going to attach it here, and that way it's all ready to go. Put a little air in there. If I can get it to unlock itself. This also gives me a little something else to hold on to while I'm doing this. So once I have all my lubricant, I don't really worry about the Lopez valve or any of these other valves at this point. I just have everything that I need right here. I'm going to go ahead and put my mannequin patient up a little bit. And for the purpose of this, I'm not going to put him all the way up or he's going to fall on his face, which is not super helpful. But I'm going to let him know what we're doing. Mr. So-and-so, we're going to go ahead and put this tube in. It's not going to be terribly comfortable, I'm sorry, but we'll try to go somewhat quickly. If he is able to tuck his chin down to his chest, I'll have him do that. If he's able to take a little sip of water, we will do that as well. So now at this point, I'm going to hold my tube nice and steady. We're going to go in one side. You want to kind of come down to the base of the nose. And a trick I always learned was if I'm going in over on this right side, I'm going to aim kind of down and towards the other ear. It's a good trick. It kind of keeps you out from going up over here or hitting the back. So with a little downward pressure and over, I'm going to come in. You are going to hit or feel a bit of pressure when you get back to the oral pharynx. That's normal. When you get back there and you feel that pressure, and I don't know if I'm actually going to feel it in this mannequin. I might not. Normally in a normal human, you'll go up into the nair and they'll kind of pull back. And then you keep going and then you'll feel kind of a stopping point. Once you get to that stopping point, that's where you're going to round the curve. So this is the point where I'm going to have my patient tuck their chin if they're able to. If they need a little help, sometimes I'll put my hand behind their head. That's also going to help push them forward if they go backwards. So they're not going to pull out. So at this point, once I hit that oral pharynx kind of in the back and I feel that resistance, I'm going to keep pressing back with a little downward pressure as I kind of push their head forward to help keep their chin down a bit. And I'm just going to keep advancing. Okay. If they can swallow, at this point, I'm going to have them start swallowing. If not, we're just going to go down, maybe. So we're going to go ahead and advance our tube to our marking, which my marking was 55. So here I am at 55. At that point, when I get to where I measured, I'm going to go ahead and try to aspirate. And what I would hope is I'll see a little like light green, light yellow, bile-y colored fluid. As long as your patient has tolerated this well, their oxygen sats are still fine, they're not coughing and gagging a ton, and you aspirate that little bit and you got a little bit of gastric contents, you can be pretty sure that you're down in the stomach. So at this point, I'm going to go ahead and secure my tube. You can use regular tape. You can use one of these little nasal knuckle Band-Aids. The big thing you want to make sure of is if your patient is sweaty or if their nose is wet, you want to make sure it's nice and dry. Sometimes I'll even use a little bit of an alcohol wipe and then and a nice like dry washcloth to wipe it off. You want to secure your bandage over the top or the bridge of their nose. Make sure it's nice and secure here. And then you want to bring the tube up, making sure that you can kind of see where your markings are. And at this point, you're going to wrap the Band-Aid around the tube here. Make sure that the bottom of your bandage here is actually on the tube. Sometimes when you wrap it just around and the Band-Aid is hooking onto itself versus the tube can slide out. So I've got it wrapped there underneath the tube, and then I bring this one up and around over here. And that way you're going to have a nice secure hold on the tube. So at this point, once I'm secure here, I'm going to come back over. I'm going to take my stethoscope, and I've got a little air in there now. You're going to come down here, give it a little air, and you should hear a nice clear bubble. If you don't, or if you listen up here and you hear your tube up here, there's a chance it maybe came down and went back up, or it's just not in the right spot. At this point, as long as you've measured, you've got gastric contents coming out, as long as you're just doing like low intermittent wall suction, you probably don't need a chest x-ray to confirm its placement. If you are giving anything down this tube, meds, tube feeding, anything like that, this is not a core track, so you do need to get a chest x-ray to confirm placement. So I'm going to go ahead and at this point, I'm going to hook up my Lopez valve. As long as you're keeping this NG up here, kind of above his head versus down here, you're not going to get drainage out of it unless he coughs. If he coughs or she coughs, it might come out, so don't point it towards your face. You're going to go ahead and put your Lopez valve on here. Suction here. You can hook up your suction. You want to just make sure your valve is turned to off up here, and then hook it up to whatever, usually low intermittent in the back. This tube here, your anti-reflux tube here, you want to make sure there's always air in this. If for some reason fluid does get up into this, it's not a huge big deal. You're going to go ahead and take your syringe, fill it with a little bit of air, and you're going to go ahead and push that fluid back down into this tube. And you can push anywhere from like 30 to 20 mils of air should get that fluid back down into here and suctioned out. Once you've made sure that there's no fluid in this tube here, you're going to go ahead and add your reflux valve. And this should help keep fluid out. So blue to blue. Make sure you don't shove this in here. If you do, it's really hard to get out. And then when this does fill with fluid and you're trying to pull it out, it doesn't. So you want it to be secure, but not so tight that you can't get it out. That's your basic NG tube insertion.